Welcome back to Season 4 of Intrinsically Motivated. I'm Tucker Clements, audio engineer and editor for Uplift Appalachia, and this is Intrinsically Motivated.
So I'm an assistant professor at the Gilling School of Global Public Health at UNC, and I've been in that position for the last 3 or 4 years. I also work part-time at the Granville-Vance Health Department. I don't really have a formal title there, but my work consists of a lot of behavioral health, mental health, and substance use work. Those are the two biggest ones. I also am the acting president of the Association of North Carolina Boards of Health. I do work on public health governance and have some smaller other type positions, but those are the biggest ones.
Okay, so the harder follow-up, because that's just a list of titles, but I guess I could ask it broadly, like, who are you? But really, with all of those things, what would you say that sums up who Karl is?
That is the hardest question. Well, so I'm Catholic. I have been Catholic for the last 8 or 9 years. And so I think that is, my first identity, if you want to use those terms. And in the world of public health, I try to do my best to both follow Christ's teaching in my individual encounters with people and communities, and in my role as an academic to bring the best of Christian theology, public health science, Catholic social teaching, etc., to bear on questions of community health and well-being.
So I'm just curious what that looks like, because UNC, what does it look like to try to bring that worldview into your work there? Does that overlap happen naturally, or is that a little bit of a struggle?
It has been more of a struggle until recently. So UNC, as you I'm sure know, is a secular public institution. And for a long time, my religious identity was something that motivated my work, certainly, and intrinsically and personally, but was not something that I really brought more explicitly to bear upon my work, whether it be teaching, practice, or research. And I think I've been long wanting to find a way to better integrate it and to do so more explicitly. And I've been fortunate that in the last couple of years, I've been involved in development of this initiative on public health and faith communities at the School of Public Health that has allowed me to do that. I can speak more freely, I think, about my own religious identity, my commitment as a Roman Catholic, both as it personally motivates me, but also as it's important for public health folks to know more generally about different faith traditions, including Roman Catholicism. And then in my work at the health department, I work with a lot of churches to address issues around substance misuse and addiction and other mental health challenges. And because that's an explicitly religious context, I also feel more free to kind of say, this is something that I'm also, convicted by. I'm also charged with, I don't worship within that district, but I obviously do in my own town. And so I experience these things, within my own church community. And so there is a kind of solidarity there, and one that's only really possible because, I can bring that more explicitly to the table. There are a lot of complexities around, navigating the boundaries of one's religious commitments in a secular institution, in a governmental institution, et cetera. And I'm happy to talk more about that. But those two places have been, homes for me recently to be more forward about that.
So I know you said you've been a practicing Catholic for 8 or 9 years now. Was that change something that then slowly built up within you to want to begin to integrate those things? Or was there something that kind of, initiated that walk for you?
So I was raised Christian, Baptist in Michigan, and without going into all the details, kind of had a coming to a faith in college, and that included a conversion from Catholicism my senior year. But ever since then, I think I've always been intrigued by different aspects of the faith, including theological, intellectual aspects of the faith. It's always been something I've kind of read and entertained on the side, and therefore has provided an intellectual vision, for my work. And in one sense, I care deeply about the integration of one's life, right? So you don't feel like you're 18 different people, in 18 different contexts. And so I wouldn't say it had been an explicit search for that kind of integration, but there was a kind of yearning for it. And I think, frankly, the Lord provided an opportunity, in these examples I've provided recently for that to be more possible. And so I've taken advantage of those opportunities and really relished in them. And it's borne real fruit. I mean, one thing I like to emphasize is that, there's a kind of malpractice that happens when public health tries to operate outside of a particular culture. And I think one's faith commitments are, at the very least, a huge part of that culture. And so I think it's good, when people can be more explicit about their commitments, whether it be religious, political, cultural, et cetera, because that's an essential aspect of health and healing. And so I both see it as important for my own personal life, but also for the work of public health more generally.
That's awesome. So I know you said you do a lot of work with substance use disorder, that sort of thing. Which came first, integrating religion or the substance? And then what is it that led you into that work specifically?
Yeah. So I've had a really odd trajectory in public health. I started, and I'll get to your question, but I'll take a little bit of an on-ramp. I started in my undergrad years at Johns Hopkins majoring in economics, and I was firstly interested in health economic analyses of programs around infectious disease in low and middle income countries. That really got me interested in the world of research generally, and specifically applying kind of econometric methods to healthcare challenges. So that got me into grad school. And then when in grad school at Carolina, I had this other pivot where I became very interested in the work of governmental public health, especially local health departments, what role they had in a kind of public health ecosystem. This was during COVID when I was a grad student. And so I had the chance to work with a lot of health departments to talk about how they were managing and responding to the pandemic. And through that, I became interested in the topic of public health governance. So all the rules and policies that govern, what governmental public health can and cannot do, the relationship between elected, appointed officials, et cetera. And then from there, I got this faculty position at UNC. But I was also interested in doing some kind of work in local governmental public health, because that's had been the focus of my dissertation research. I wanted to be involved somewhere, kind of boots on the ground. And this health department, Granville Vance, was hiring for someone to coordinate their mental health and substance use related programs. And it was a health department that was close to UNC. I had relationships with the staff and some of the leadership beforehand. And so I applied for the position, and frankly, having no background, in that topic whatsoever. I was more kind of interested in, local public health as such, as opposed to the particular topic. And so it was a huge learning curve, when I first arrived on scene, to understand. I mean, I'm still learning, certainly, all the complexities in this, vast topic. So we started doing this work. It was federally funded. And again, I want to go into too much detail unless you have further questions. But basically, one of the pastors in the community, one of the the main pastors, who was at the time was also serving as a representative in the district, he was interested in hosting a forum on mental health and addiction as part of his role as a representative. And he asked the health department if we'd like to partner with him on that. And it was at those forums that him and I really kind of connected. His name is Frank Sossaman, around this idea of, what would it look like to develop something that, more explicitly engaged and worked with churches to address this topic. And so that was maybe 2 or 3 years ago. And so we've been working together ever since. So the substance use and addiction, mental health more generally, was kind of first, though I was very uninitiated to it. And then this kind of happenstance partnership developed. And that's been one of the main kind of domains in which I've been working. I would say, and again, can talk more or less about this depending on your interest. I've also been doing a lot of work around youth mental health and social media and digital technology. I work a lot in my own district in Orange County around policies and programs around that. I work as part of a parent coalition that's trying to kind of build momentum around these topics. So, but yeah, for the other part, it was mostly the behavioral health, mental health stuff, and then
right.
the religious component.
Well, and I know you said you kind of happenstance found your way into it, but I mean, it seems like each of those steps is kind of building on one to kind of prepare you
right.
for where you ended up. So, I mean, I would say it wasn't so happenstance, but rather just a series of events, divinely
yes.
orchestrated by God that have brought you to this place that you are, and now you're getting to integrate the faith part back into that work. And I know you said there are some challenges and struggles with that. And that's the world that we kind of navigate all the time, is trying to help, prepare churches to work well with organizations, whether it's public health focused or government or
right.
whatever it is, but also prepare
right.
public health organizations to work well with churches, because they speak completely different languages. I know you've said you've had some of those
right.
kind of challenges in seeing that happen. What are some of those things, that the struggles from either side? Because you can also see it from both perspectives. What are some of those struggles of getting these two seemingly completely different groups of people to be able to work well together for the good of other people? Yeah,
no, that's like the $1 billion question.
Right. That's why I'm asking, because I want you to answer it for me.
Yeah, right. I'll start with the solution in some respect, and I'll walk back to the challenges. The
Perfect.
solution really is relationship building, between these two entities.
Yeah.
Like in so many arenas in society where there's this perceived conflict, the actual conflict is so much smaller than the perception. And there's so much opportunity for kind of a pragmatic approach to addressing, some challenge that does not kind of, cling to some of the big kind of ideological divisions, whether it's political divisions, religious divisions, divisions within the academy, et cetera. And so the more you spend time with people, the more public health folks spend time with religious folks, that goes a long way towards reconcile some things. But to address the challenges, I think there is a tendency in public health to favor a certain kind of epistemology, right? That is grounded in what people perceive to be the scientific method, and all knowledge about the body, all knowledge about policy effectiveness, all knowledge about, program effectiveness, about what public health is seemingly derived from this, secular method, right, of developing hypotheses, collecting data, testing those data against hypotheses. And I think when public health sometimes steps into a religious environment, they can be worried, about what to do with that, and how that is reconciled or not with other forms of epistemology, whether that's, divine revelation in scripture, whether that's one's, own spiritual experiences, one's sense of the Holy Spirit, right, in Christian contexts. And so I think that is one and perhaps the most, fundamental division. And we can talk again about particular examples there. But I think in one sense, to address that, I think both religious communities can be a little bit more open to, what modern science has established about various things about the body, what the scientific method can do to help us, know what's worked, elsewhere to guide what could work here. I mean, talking about kind of evidence-based practices, et cetera, stuff. And then I think public health can go a long way towards recognizing the limits of the scientific method, and recognizing that there are other forms of knowing, that there are a lot of forms of evidence that does not, nicely kind of present itself in a scientific format. And that the kind of language of science is often kind of inaccessible to just lay people, who may be interested in addressing a given topic. So it does kind of alienate people when you are too dependent upon the kind of evidence-based scientific findings, academic research, et cetera. I think that's a big one. I think the other thing maybe is, I think public health across a lot of issues, and maybe substance use is an example, par excellence, of being really nervous about how they have perceived religious communities as being stigmatizing, towards various topics, whether it be addiction, whether it be about gender and sexuality, all these different topics, that there can be this perception, among public health, which tends to lean progressive, on various topics, that, the religious communities are going to be more traditional, are going to, more moralizing than public health is often comfortable with. And so I think, there's a way for, again, in that maybe intersection, especially to cut through some of the kind of stereotypes, of what religious communities think about stigma, or their understanding of it, or how they've moralized or not a particular topic, and just to ground it in what are some particular narratives or particular testimonies or particular cases in which these two different ways of understanding a challenge have been understood and reconciled.
Yeah, and I think a lot of times that's, like you said, solved by better connection, better community, better, knowing the other people. And I mean, in a lot of our work that we do, churches are afraid to help people struggling with addiction until they meet this one individual. Once they meet somebody and it's a person and not just an idea, it makes it easier for people to work together. And I think that tends to be the case between, public health organizations, churches. It's like, if the public health is afraid of the moralizing for the church, and the church is afraid of the secularizing of the public health organization, a lot of times it's finding, the humanity within the shared work, which is the people we're trying to see helped. And I think, and we do a lot of, not telling churches not to moralize, because they obviously have a whole moral framework that defines everything that they believe. But we try to help organizations understand, here's why they are believing the things that they do. And here's also why we believe you can trust them with people, and that it's still going to be good for them in the long run. And then we also, and I know you said churches often seem to be more accepting of evidence and these sorts of things. Sometimes that's true, but I mean, we're trying to integrate, trauma-informed care into the church, that sort of thing. And there are pockets within the church that, not to say that we're trying to say the Bible isn't the key text that we should define everything by, but that to understand the science, to understand the evidence, to understand, the way our brains and our bodies work, isn't to diminish the importance of Scripture. But there are a lot of churches that are still resistant to that, because they think all we need is the Bible. And in a way of saying that, that's true. But in a way of saying that, it's like the Bible also says, God created us this way. He gave us bodies that function this way. And he speaks a lot to the way that our bodies are meant to function. And so there are things that we can test through the scientific method, like you were saying, that confirm what the Bible's saying all along. And so there is still this layer of mistrust going in both directions that's hard to overcome. And I know you were saying that public health has at times either misused the scientific method, or I think in a lot of the examples that we run across, it tends to be our kind of echo chambering the evidence that they're using to say evidence-based. The evidence says this, so we trust this evidence, but we're not testing it against the right things, or we're not testing against different things, because for whatever, and again, for whatever is motivating it. Oftentimes it's financial, but not the only thing. But that we all sometimes have to take a step back and say, why is it that we are so entrenched in whatever place that we are? And then ask, how can we be approaching that better? And it sounds like that's some of the stuff that you're wanting to explore a little bit in your work.
Right. Yeah. I mean, I think I would also maybe add, as a normative framework, I think as a normative framework, I think public health should be generally oriented towards empowering the people who are most directly affected by these topics. And that tends to be, non-professionals, and that tends to be non-scientists, right? And so I think when it comes to a question like, what is the appropriateness of the scientific method, within public health research, programming, practice, et cetera, there's one sense in which you can look, just at the method itself and identify its limitations, its usefulness, et cetera, how to be wise, about that. I mean, as for starters, I think there's a kind of malpractice that happens when people, refer to the evidence and they don't actually know what they're referring to. It's kind of weaponized, right? Like, you should have a firm understanding, right, of the limitations of that data, the limitations of the studies, the biases of the studies, if you're going to be faithfully stewarding, that body of knowledge. So there's all these considerations for, understanding how to, the usefulness of science as such. But then again, as this normative framework, I think there should be this additional, burden of proof, so to speak, to say every time, we kind of push towards, the scientification of something, it does tend to separate, the people who are directly affected by some topic, right, and their ability to understand and find solutions to address it. And that's not to say that we shouldn't use, evidence-based programming or the scientific method to understand things. It just says like, that tends to introduce a kind of alienating language or technical language that most people aren't comfortable with, And so if you're not careful, it can increasingly kind of contribute to this divide that I think is a chasm right now, really, between the kind of public health scientist professional and the community member who has their own kind of, way of understanding, whether it be, addiction, whether it be, chronic health diseases like heart disease, diabetes, et cetera, whether it be some environmental thing they're challenged with, and they understand it in different terms. And so, any kind of technical apparatus we develop, which science is one of those, should ultimately serve people.
Right. Well, and I think it's interesting that you're talking about the language that we use, because if we can't change the way that we're saying things to help people understand what we mean by it, not just what we're saying, that's, I think, how you end up in that trap of saying, well, you're just gonna have to trust me. If you don't understand the words that I'm using, we say, well, then just trust me. And I think that is what leads to building up a whole lot of mistrust when you're just being told, oh, just listen to me, just trust me, without being able to make people understand it, which leads to, I think, understandably, a lot of the skepticism that we see in our whole society right now surrounding public health in general. Not trying to get too down into the weeds, into the political nature of everything, but I think there is a lot of uneasiness with regard to talking about matters of public health and stuff. I mean, coming out of the pandemic, it was, it seemed that we were creating this, you could only be of two minds. You could either be all in, trust whatever anybody tells you, or I'm not going to trust anything anybody says. And there was no room for conversation in the middle. And so I think a lot of times it really is, we do have to, try to train ourselves to understand the language of the people that we're talking with, which is a hard thing to do for, the untrained, common folk in the society, to try to understand all this, really, highfalutin, difficult language that all these, academics use. But it's just as hard sometimes to let go of the language that we understand things in and try to in a sense,
Right.
simplify it in a way that's going to, but I think the effort also to try to find that common ground from both directions creates an
Right.
atmosphere where better conversation is going to be able to happen anyways.
Right. And I really do think particular cases and narrative is is a way out of that. It's like, again, not to get too philosophical, but like you start with this phenomena you have in front of you, right? And then we develop over time different cultures to describe that phenomena as such, and they can be, again, increasingly kind of divorced from one another. And so it's sometimes helpful to just say, okay, like I'm not at my heart a public health scientist. I'm a person, who's trying to grapple with this complex phenomena. Like, what do I see in front of me? What do you see in front of you? And there's a way we can kind of start from there, as opposed to here is the kind of model that I'm bringing to this, or here's the framework I'm bringing to this, or this is what I've been taught in class of how to see this thing. Start with the phenomena as such.
So what are the ways that you're practically trying to accomplish this sort of stuff right now? What are there particular projects that you're working in? Is there a particular, what is that looking like for you?
So one easy answer to that is I've developed a class at the School of Public Health right now that's on public health and faith communities. And so we tackle all of these things. And we try to do so in a way that is also, bringing in faith leaders, religious leaders to talk about, their own understanding of health and disease and how their faith community has been involved in addressing it. I mean, we had a visit to a synagogue, the other day, in which the rabbi, walked through portions of the Old Testament, with students, portions of various, Hebrew scriptures, talked about their experience during COVID, different ministries they have. So again, trying to like bring it to earth, right? Like this is a real person, real community, real faith commitments. This is how it's translated into, their work to address community health. That's one application, and I've really enjoyed that. There's so many interesting, as our discussion has already revealed, both practical discussions to be had, but also big picture things. I mean, I think it's a lively debate, to ask what role should religious, viewpoints have in the public sphere. We are a so-called liberal democracy that, champions, public reason, right? The ability to defend your position in the public sphere without recourse to some kind of, tradition, or without some kind of, recourse to a religious ideology. And yet it's more complicated than that. People bring their commitments all the time to public debates. Even elected officials do that. Even scientists do that, right? So there's good kind of philosophical questions to ask there. So that course has been really fun to teach and to learn alongside students. And then in the health department, we've developed this, program around, we call it faith and mental health, basically working with churches to, empower them, to work alongside them, to address issues of substance misuse, addiction, and mental illness in their congregation and community. And we have a forum, upcoming. It's just one example that's specific to substance use and addiction, and how we've structured that. And I hope it goes well. It hasn't happened yet, but is foregrounding, different narratives, so we have identified folks from different churches who have some kind of, real lived experience with addiction that they'd like to share with the community, and, share not only what that experience has been like, but what has their encounter with the church been like? What did they want from the church? What was their encounter with the health department or public health like? And so we have, 5 or 6 different people who are going to kind of give a little testimony or story. And that's, again, our attempt to say, there are these big debates, abstinence-based, approaches, medication-based approaches, understanding of addiction as a spiritual issue versus a social issue versus a brain chemistry issue, there's these kind of academic type debates, which are important and worth discussing, but really trying to ground it in like, here are, real people, and it's complex, and I've had conversations with all these people, and there's not like a simple through line, of how they understood this thing for themselves, how they ultimately got help, how they've helped others. And so we have that. And again, that's kind of our attempt to say, these things are not fundamentally opposed to each other, a kind of understanding of public health and the religious commitments. But we also don't at the end of the day, we're not forcing churches to do anything,
Right.
like if they want to respond and they want to develop their own programming, their own ministries, they do it in their own terms,
Right.
and we as a health department, try to provide them with resources and connections in a way that hopefully doesn't kind of implicitly push them in one way or the other. It really should be on their own terms. And again, that's just to recognize that a particular community's agency matters, that particular culture matters, right? Like if it's going to be successful, it can't just be some top-down public health program, right? So that's been one other practical example.
So how do your peers view that approach? Because I do think, like you said, that kind of top-down, one-size-fits-all, here's the pamphlets that we want all the churches to pass out, I think has been kind of a traditional approach.
Right.
That has probably not worked to varying degrees. But it sounds like in that we want to be there with you, we want to be a resource, we want to help, but in the end, it's still your religious tradition that's going to work it out the way you're going to work it out. Sounds a lot more like you're empowering the churches and allowing the churches to still hold on to kind of that moral fiber in their being,
right?
And not undermining that part of it as well. How's that approach been thought of in the circles that you're walking in, more on the public health side, the academic side, whatever that looks like?
I think there are real tensions, and I think we're still kind of working out some of those tensions, frankly. I think there are folks who, I would call them more public health believer types, who are really hesitant towards, inviting certain speakers, for instance, who, may not carry the kind of public health message in the exact same way that they would, wouldn't ground what they're saying in, the evidence base or whatever you want to call it. I think there's this presumption, again, that churches have played a huge role in stigmatizing, substance use and addiction because they've moralized it. And I think a lot of folks in the health department, and some particular people come to mind, are very worried about that continuing. And so they're very interested in, for instance, providing trainings, for churches to basically, learn that addiction is a brain disease,
right?
And that's the way out of it. And again, the challenge of my position, and I am learning more and more every day, is to try and broker, in one sense, these different relationships, if it's going to be sustainable. I mean, one other example, the county has received settlement, money from the opioid settlement funds, and I know for a fact that early on when they received the funds, there was a faith-based ministry around providing short-term housing, I think 90-day housing for folks with addiction. And but it's based in scripture. There's Bible studies the whole time. They are very much leading with faith and explicitly saying that is an important, if not essential, aspect of recovery. And they had a conversation with someone in public health about receiving funding from the settlement funds, and they were really turned off from each other. The person in public health was really skeptical, that they were going to use the money responsibly, or they weren't going to use it for conversion, or what's the other word? proselytizing.
Right.
Sometimes you hear that word, right? And so they're like, that never happened, and so the person didn't get any resources from the settlement funds. Public health person, I don't think, was able to appreciate in one sense the fullness of the work that was being done. And so again, without like, because I've had conversations with both of these people, and to the folks in the faith-based ministry, I want to tell them, like, I don't want you to compromise your values. I don't want you to compromise your commitments, your convictions, how you do things. But I also want you to be able to receive resources, for the work. And if you're interested in receiving them from a public authority, like, you just may have to emphasize different things, and speak more to the kind of results of the program, as such, the people who have been meaningfully helped with it, as opposed to, some of the faith commitment as strongly. And again, that's up to them.
Right.
I'm not trying to push them one way or the other, but there is a common ground is going to be a little bit less than, either side's kind of, major commitments.
Yeah, I guess that kind of goes back to, though, what counts as evidence-based, because one of the things that we're interested in proving, because I think given long enough, I think we would be able to prove that if these churches or these faith-based organizations were allowed to practice their faith properly. Now, again, the other hard part of that is to get them to want to do that. That's the elephant in the room, is the church has to want to, step up to the plate on that. But we think if you actually would just allow them that full range of freedom, here, practice understanding the morality that your faith, kind of boxes you into, using the language that Scripture has given you, whatever that may be, that still also could be effective, if not more effective in the long run for people. But the rest of the evidence-based community is, and maybe it's fear, maybe it's just they are just so dismissive of it because they just don't believe it. And I understand that people just don't believe the same things that people in the faith community believe, so they just don't even want to consider it. But I think, to me, part of the evidence-based thing would be like, what if we just tested it? What if we let that religious organization be as religious as they wanted to be, and let's see what their results actually are? Now, I would argue, I believe that if the church were to practice being the church the way that it's supposed to be, tested against anything else over the long run, and I say that over the long run, I think you could have much more effective, flourishing lives for the people that they're ministering to. Right. Now, if it doesn't work, it doesn't mean that it's not still true. It might mean that church was not doing it well. I don't know. Like, there's so much more work that could be done to equip churches to do it well too. There's all these factors, but there is the kind of this disconnect, this fear. Well, we can't let that faith organization practice it that way. Well, what if that's what's making it effective too? And so it's like, I wish that, and I think this is kind of that tightrope that you're walking, and it's a tightrope that we walk too, because, we have grants that fund us, and we want to make sure that we're still able to receive the resources that we can get. And so we're careful in the way that we write things, but I hate that we can't just unashamedly say, we're going to test Christianity against everything else.
Yeah, I think I think I would just love for it to go both ways, and I think you would love that too. Both where, and these are just very complex. I'm not trying to solve this on a podcast, but if we do solve it on a podcast, though, we'll just package it and sell it for a whole lot of money, and then we'll fund everything that both of us are doing. So, yeah, but you want it to be both ways. I mean, I think, and I maybe I'm pushing more on the public health side right now, just because that's where I feel like I am more embedded and may have more influence, but of encouraging public health folks to expand, their understanding of evidence as such, to not, in one sense, hold, churches or other faith communities to the same kind of standard as, a randomized controlled trial. And yet, I think there's also work to be done, on the side that you're advocating for too. Like what could, an evidence-based approach to researching, thoroughly faith-based efforts look like, and what can those methods witness, to ultimately. I think that the thing that I'm sure you guys wrestle with and are very conscientious of is like doing that in a way that does not corrupt, or malign or push in a certain direction, like what the church is called to.
Right. Yeah. It's like and that's, I think it's like, and that's the hard part, and that's the conversation that we're having with on the church side right now is like, we are not asking you to say, when I say the Bible isn't everything, I don't mean that. I mean, the Bible is still, Scripture is going to supersede everything. However, we can also understand that we live in a created society and God gave us, all this common knowledge and all of these. There are lots more conversations that can be had that ultimately just reinforce what I think Scripture said. And I think there is, just like there's fear on the public health side, there's fear on the faith side to say we don't want to be corrupted. And I appreciate that, but I do think sometimes, just like I think public health can be overly cautious, I think the church can be overly cautious too. And that sometimes just means that they're slow at getting started on something. And that's what I tend to push back against is I appreciate that you're wanting to cross every I, dot every T, understand every single little aspect, make sure that, but at the same time, there are real people with real struggles that we really need to be serving. And we're the ones that can be doing something really meaningful right now, even if it means that we're not going to do it perfectly as we start to jump in. We want to do the best we can. We want to be as, true to Scripture as we can be. And I think that there's a way that we can start and refine as we go. But if we have it, we're never going to figure out, we're waiting for perfect for the sake of good right now. And I think that tends to be the thing that holds us back. And maybe that's the thing that holds back that whole that cross collaboration conversation too, is both sides are looking for their own perfect version, and we can't find that. What's the good thing that we can be doing as we work out the details the rest of the way?
Compromise. Yeah. And it should be pursued in charity. I mean, that's right. Like, whenever you're trying to communicate across difference, and this is true in one's marriage, it is in professional world, right? Like, you're trying to, out of charity, speak in a way that's understandable to the other person, right? And so finding ground is not just this kind of technical, public policy type thing. It's really, in one sense, out of the goodness of one's heart for love of the other.
I was going to say, finding the humanity in everything, I think, seems to be, and I think that's where you started. You said, I'm going to start with the solution, then we can talk about how we get there. But your solution was, finding that humanity in the people that we're working with, in our own circles, in our own kind of silos, and the people in the silos that we think we're trying to stay away from so they don't corrupt us or whatever. But it's like finding the humanity in both and finding the thing that's motivating them too. Like it may be an opposed worldview, but there's still something motivating. And if we can better understand each other's motivations, I think that's going to make it easier for us to have more effective collaboration going forward.
Yeah. And just recognizing, and I don't want to keep belaboring this point, but like I go back to the normative framework where like public health should be oriented in such a way that empowers actual communities. And like, that's the test at the end of the day. Has the particular community been empowered to act? If they've been, alienated, if they've been, stripped of their agency, if they've been stripped of their language and all these ways that kind of put them to the side, like that is bad.
Right.
So that is kind of a test. I mean, it's a complicated test, but for me, that is a test.
So you're teaching, you're trying to do these collaborative events. What are the things that you're hopeful to see happening short, medium, long term?
I would love for, so at the School of Public Health, I would love to be a part of developing a more robust, menu of programming around this intersection. I mean, everything from having funding, for public health folks to better work with, religious communities, for training around this, for workshops, for conferences, symposia, fellowships, research portfolios, et cetera. I just think there's so much in this space. And I'm not coming to it, you know, there's a lot that's been done here. I'm not trying to presume that I'm the first guy who stumbled upon this. I would love for Gilling, as the School of Public Health, to be more forward about that. And I think they should. I think especially in North Carolina, in which, in many areas, especially rural areas, the faith community, in particular Christianity, just is like a core community institution. Again, to like not engage with that is a kind of malpractice. So that's like one big picture goal. I think practically, I probably enjoy more some of the particular relationships I'm building, at the health department with churches than like the big picture academic stuff, because that's really, I think, where a lot of the fun is. And I'm excited to continue developing these kinds of relationships and in a sense to test, more and more where there is productive collaboration. And for that to be sustainable, I think that's a big question for me right now. I mean, it's been maybe a little over a year or so, maybe 2 years since we've really started talking about this. And I have a lot of questions around, how do you make these kinds of partnerships sustainable in a way that doesn't corrupt them? That way that doesn't just make it into a kind of government program, like any other government program that gets kind of translated into all the institutional metrics and bureaucracy and what have you. So that is a big open question, for me. And then, yeah, personally, I think just continue to explore this intersection myself. I feel like there's still a lot that I'm learning personally about, how my faith commitments, translate into public health. I'm sure it's going to be a learning experience, over the next whole lifetime, honestly. So I don't know. I feel like I'm kind of at the start. I'm only 30. I've been at this school for a couple of years, and this could be, a lifetime's worth of work. So I have no idea.
And for those that are listening, you did not notice me really fighting that eye roll when he said he was 30, as I'm sitting here thinking through my lower back pain as I get older and these sorts of things.
Well, I have it too now. So. Okay,
yeah. Well, wait till you hit 40. Then it's like you turn your head to the left slightly, and you're going to feel it for a week or something. Now, I'm going to ask you one more question, and this is very open-ended. So you can answer this in any way, in any aspect that you want to. It doesn't have to be specifically focusing on public health in the church, but it can be. Because I just love hearing people's different kinds of responses. So what right now are you excited about? What excites you?
I think there's a real opportunity in public health right now to reestablish, in one sense, the roots of the work. And I say that to say, so there's been a lot of reflection, writing, institution building at the intersection of medicine and theology. And, I think there's good reasons for that. If you think about the history of medicine, it starts in the church, and it starts in monasteries. And if you look at scripture, Christ is referred to as a healer, as a physician. He's attending to particular sick people, in a way that a physician does. Public health, doesn't really start until the 19th century, when you have, basically the rise of industrialization, and all these people have been rapidly displaced or dislocated from various kind of more rural agricultural, smaller town backgrounds into these, industrial cities, Manchester, London, New York, etc. And it also begins in this kind of era of, just after the Enlightenment or still in the Enlightenment, in a kind of age in which humanity is very high on its optimism of what the scientific method can reveal, what reason itself can perceive and understand. You have folks like Kant and Hume and Locke, who are trying to push that boundary. In other words, it does not start within a kind of religious context, really. I mean, obviously, there are people at the birth of modern public health and have always been that bring religious commitments to bear. But it really starts in a kind of secular public arena. At least that's my reading of it. And, I could talk for 10 hours about this, but I think we've kind of exhausted that. A purely public, a purely governmental, purely secular approach to public health. And I think we have an opportunity in the 21st century when so many things feels like are kind of being shaken up a bit to say, wait a second, like we need to revisit some of these basic assumptions, that have kind of been baked into what we think public health is, and that have kind of reached their tipping point. I mean, the whole question around, the limitations and applicability of the scientific method is just one example of that, thinking about public health as an independent profession versus something, we do collectively as society, thinking about the importance of culture, right? And helping us understand what health even is and what it's for. Being increasingly kind of critical of the kind of technocratic paradigm that has been described in many places, that seeks to kind of control the world through various, technologies or technical applications, as opposed to a posture of receptivity, a posture of relationality. So, and all these things have religious kind of connotations to them, or at least they can be. And I think there's actually a really important opportunity, an exciting opportunity for religious communities to provide a kind of a corrective, to what public health has become. They're not the only voice, that I think should be involved in kind of co-creating what's next, but I think they're an essential one and maybe a kind of neglected one. And maybe that's in part responsible for what we see nowadays in public health's kind of malaise. So that's what I'm excited about.
I hear why you say you could talk about that for 10 hours. I have 10 hours of questions, but I don't have time to ask you all of those questions. Because just because I have been thinking about the role of public health within and the role of the church together for a long time now, and you've just sparked so many new questions in my brain that I'm gonna have to go process, and then we'll follow back up when I have time.
Give me a call.
Yeah, we'll definitely do that, because I think that, oh wow, there's so okay. I gotta stop myself, or we'll go for another hour, and we don't have it. So this has been for me just super encouraging, because it's interesting, because I know we overlap in a lot of the places that we are having conversations, but where you are a little, it's like if we're meeting in the middle, you're kind of coming from the public health side, and I'm kind of coming from the church side. So it's cool to see both sides working toward one another, and I see this kind of beautiful picture of where we can be. And so for me, this conversation has been really enlightening, but also just encouraging to see the momentum in that direction. And so I'm really excited to see what you guys are able to keep doing. And I know we're going to be collaborating, because
I'm sure
you're copied on so many emails that I'm copied on right now. So I'm sure we'll continue to be working together a long time, and hopefully we'll be able to really shake up kind of what the standard is, and really maybe move towards something that's going to be more effective in the long term. So thank you so much for being on, and we'll continue to press forward toward, bigger and brighter things.
Awesome. Well, keep up the good work. Appreciate it.
Yep.
This has been a podcast powered by Uplift Appalachia. To learn more, you can find us at upliftappalachia.org or at upliftappalachia on Instagram.